This is really an extraordinary institution with so many leading people, leading physicians, Nobel Prize winners, advancing diseases across the spectrum when it comes to neuroscience, when it comes to cancer, when it comes to so many areas.
We're here based on this knowledge that we are trying to solve the most difficult and most challenging cases. And they're not impossible to us, they're just unknown for now, unsolved for now.
Jonathan is a young gentleman who has medically refractory epilepsy, which is more complex than the usual one because it has bilateral foci. So interneurons, which of course can be done in both hemispheres, are a very elegant way to treat this specific pathology.
Talking to patients with drug-resistant epilepsy is a really scary time for these patients. They don't know what's going to happen. They don't know when they're going to have seizures or how that's going to affect their lives.
For epilepsy, it's the paradigm shift, the concept that we're not just doing mechanical removal of areas that contain the epileptic focus, we are modifying the focus. We are using very sophisticated imaging to do the least damage with the highest efficacy.
Other treatment options besides medications include a ketogenic diet, include neuromodulation with a variety of devices. There are also resective and ablative surgeries where we can identify where seizures start and remove those. And then finally, we're looking at ways of delivering cells that by themselves can inhibit seizures without requiring taking anything out. We're really at the forefront of new techniques for identifying and treating epilepsy in ways that haven't been done before.
What UCM offers and the neurologists that I work with offer is a lot of experience with a lot of these different conditions, including rare neurologic conditions. And sometimes it can be really comforting for a patient to hear, I've seen this before. This is not unusual to the presentation of this diagnosis, and I've seen patients like you before, and I've seen patients do really well.
We play the foundational role in the development of awake craniotomy for patients with tumors or lesions in eloquent brain, in the areas that control speech, memory, or motor or sensory function. And we developed this technique almost now 3 decades ago in order to be able to resect a tumor as completely as possible while preserving brain function. It is like walking a tightrope between tumor resection and preservation of function.
Movement disorder surgery, like epilepsy surgery and like tumor surgery, is a team sport. So you have the neuro-oncologist working with you, the epileptologist and the movement disorder neurologist.
Dr. Wanke, we have been working together for more than 15 years. We are really a good team, and this is one of the reasons that our DBS program have been so successful. Deeper brain stimulation is a new technology stimulating certain deeper brain area to achieve the better symptom control, particularly coordination, immune disorder, including Parkinson's disease, tremor, and dystonia.
About a decade ago, ambulances would take a stroke patient, a suspected stroke patient, to the nearest hospital. That was okay when there were no specific time-sensitive treatments. But as we have more treatments that actually can reverse the signs of a stroke, if given at the right hospital at the right time, we now know that you should get to that hospital sooner. Otherwise, you'll delay treatments that could then, of course, lead to worse outcomes.
When I do speak to patients who are having an acute stroke, time is of the essence. Every minute that we delay this treatment, patients can lose 2 million neurons. It adds to the disability of patients up to 1 week for every minute that we delay. For 50 years or so, the only treatments we really had for stroke and for neurological disease was aspirin and blood pressure reduction, which are really great and important therapies. But in recent years, we've seen an explosion of innovation.
One of the biggest innovations that we've done is our work in intracerebral hemorrhage. The University of Chicago has defined how that disease is treated, and we've had major input on the guidelines for the treatment of intracerebral hemorrhage, which is one of the most devastating forms of stroke that occurs. Even though you may only be meeting with a small team of doctors in a small room, that comes with the weight of the University of Chicago, and that's a very powerful thing.
The robotic hand is a fairly unique Freiburg/Pittsburgh project. Our robotic hand is very different. It has pressure sensors in the robotic fingers, and we feed back the pressure to the sensory cortex. So the patient cannot only use the hand, he also feels what he's doing, which that's why we call it a biomimetic robotic hand. We can draw a letter on a fingertip, and we can draw it also on the cortical neurons, and the patient tells us where we drew the letter and what shape it is.
Doctors should think of us as the end of the line. We can deliver care when you feel like there's a patient who needs the top of the line, the most cutting edge, potentially experimental treatments.
When you send a patient to the University of Chicago, you can be confident that you're getting exceptional physicians, exceptional allied health, and people will work in teams across departments and across centers and service lines to do the best for each patient.